So Mary Beth Martin, say
Morning, everybody.
thank you so much. And our boss, Dr. Lois.
Good morning, everyone.
Thank you so much. Yes, you can go on. Thank you.
Okay, good morning, everyone, and thank you for joining. Apologies for a slight late start. We had a technical issue, but I'll be taking you through current case management. Sorry, just 1 second. So just allow me to start sharing my slides. Okay, Thuranira, kindly ask them to stop sharing that screen so that I can share my screen.
So Nelson, please put down this flyer.
Okay. All right, so we'll just go through some updates on case management. I know many counties may be struggling with how to manage patients, but you also have a lot of mismanagement, self-mismanagement in the community. So hopefully this can equip you then to talk to your patients and to educate your communities as well. So we'll start off by what are considered some potential drug targets for COVID-19. So one, there may be antivirals, and we look at the potential antivirals that have been tested and what the evidence for that is. There may be drugs that act as anti-inflammatory agents. So things like steroids, for example, would be anti-inflammatory. Then there's also a role for anticoagulation as well. So we'll look at some of this as we go on. So one, I sort of shared this slide last week. So usually if someone gets infected, the initial phase of this infection is viral replication. And often viral replication, the start of viral replication will precede the onset of symptoms. So you may find that the highest viral loads are really early after, when someone is still symptomatic, but very early in disease is when you'll have a lot of virus. After that phase, the inflammatory system comes in, and the virus is contained. So the level of virus goes down as the inflammatory process rises. And we have some things that are inflammatory markers that are found to be quite high during this phase. So the higher the inflammation, the higher the symptomatology. So by the time someone is coming with, difficulty in breathing, when you're doing an X-ray or a CT scan and seeing a lot of infiltrates, a lot of that is because of the inflammatory response. So in terms of treatment, if you thought about it, antivirals would work if given very early before there's too much viral replication. And a lot of the anti-inflammatory agents would work during this inflammatory phase of disease. So I then went on to just want to look at the various treatments that people are using there and look at the evidence for these various things. So one, if you think of high-dose zinc, I wish I could ask everyone to raise their hands to tell me who's prescribed or taken zinc and taken vitamin C. And what is the role of this? Should people be taking zinc at home? Should we be prescribing zinc or vitamin C? And this study, this was carried out in the US, looked at the effect of high-dose zinc and high-dose vitamin C versus usual care. And usual care was really, these are patients who are outpatients that continue with their routine medicines. If they're antihypertensives, they continue with those. If they're on diabetic treatment, they continue with those without an additional treatment specifically for COVID. So they enrolled just over 200 patients. These were adult patients with SARS-CoV-2 confirmed by PCR. And these were patients who presented to hospital but were managed as outpatients. And they divided them into 4 groups. One was given the standard of care. One was given vitamin C at a fairly high dose. One was given zinc, and one was given the combination of zinc and vitamin C. The primary endpoint was the number of days required to self-report a 50% reduction in symptoms, such as the severity of fever, cough, of shortness of breath, or fatigue. So they followed up these patients, and the last panel here looks at sort of the outcomes. Remember, the outcome was number of days required to reach a 50% reduction in symptoms. And when looking at patients who are in the usual care arm versus those on ascorbic acid, on zinc, or zinc and ascorbic acid, there was no difference in outcomes. So basically, vitamin C, zinc do not impact outcomes. Hence, we shouldn't be prescribing them, and we should also encourage patients not to take them. The next thing was high dose vitamin D. And again, there's been a lot of issues around high dose vitamin D, or Africans may have some vitamin D deficiency. And this study looked at randomizing patients to either high dose vitamin D or placebo. Okay, and these were patients with either moderate to severe COVID-19. So looking at this, they looked at the probability of discharge from hospital, and they also looked at patients who had low vitamin D levels. So is it that if you have enough vitamin D, it's okay, but if you have low vitamin D, it needs to be supplemented? So looking at the outcomes of these two patients in terms of probability of discharge, there was no difference between the vitamin D and the placebo group. When they looked at the subgroup of patients who had vitamin D deficiency, so they measured the vitamin D levels, even in the subgroup of patients with vitamin D deficiency, supplementing vitamin D had no impact on the probability of hospital discharge. So again, this basically tells us that vitamin D has no impact on outcomes in patients with COVID. And this is in patients with moderate to severe disease. The next thing I want to look at is steroids. We've had data from recovery trial, which is really the largest trial that gave us sufficient data on steroids. So the recovery trial is a large trial with enrollment from multiple centers. They've already recruited, I think, more than 40,000 patients in total. But at the time they gave us data on dexamethasone, they recruited just about 11,000 patients. Patients were recruited to different treatments, and one of those treatment arms was dexamethasone, and they looked at dexamethasone compared to a control, which was whatever was standard of care at that point. This was fairly early on in COVID, so there wasn't very much given as standard of care. And they followed up these patients and basically looking at the results. So some of their endpoints were mortality. And they looked at mortality in different groups of patients. In patients who did not require oxygen, so these are patients who are well, who are at home, or even if in hospital, the oxygen saturations are high, not requiring oxygen. They also looked at patients who are on oxygen and patients who required invasive mechanical ventilation. So looking at the top right panel, for patients who did not require oxygen, dexamethasone did not improve outcomes. If anything, there was a trend towards worse outcomes in those patients. What does that mean for us? If a patient is at home on home-based care, or if a patient is in the hospital but does not require oxygen, then we should not give dexamethasone. For patients who are on oxygen only, there was a reduction of about 12.5% in mortality, okay? For patients who are on ventilation, there was a reduction, a significant reduction in mortality. So if you have patients who require oxygen, so patients with severe illness, then those patients should be put on dexamethasone. The dose of dexamethasone used in this study was 6 milligrams once a day. There have been other studies looking at the impact of steroids. Sorry, just to finish with recovery, they also looked at various subgroups of patients, and as I've said, dexamethasone showed better outcomes than the usual care arm. Okay, so this is sort of a meta-analysis of various other trials looking at various doses of steroids. And again, most of the studies showed that steroids were better than no steroids for patients with severe illness. One of the questions that we've been asked is that if a patient is not doing well on low-dose steroids, should we give them high-dose steroids? And I think in a lot of hospitals, people are going on to give high-dose steroids. And there are certain studies that have also looked at the implications of giving high-dose steroids. And the REACT trial looked at patients. It was sort of a meta-analysis of various studies. And they looked at trials that had administered low-dose steroids and compared that with trials that administered high-dose steroids, okay? And they found that for trials that administered high-dose steroids, there was a higher risk for worse outcomes, a higher risk for worse outcomes than for those trials where there was low-dose steroids administered. So again, we do not have sufficient evidence to suggest that high-dose steroids lead to better outcomes in COVID-19. Again, other studies that have looked at high versus standard doses of COVID-19, this particular study again looked at quite a number of patients, close to 600, and some were treated with high-dose steroids and some with low-dose steroids, and they looked at the outcomes. And basically, on the y-axis of this chart is mortality or prediction of mortality, and on the x-axis is the age of patients. And what they showed, which was interesting, is that for older patients, high-dose steroids was actually associated with a higher predicted mortality. So just to repeat, at this point, we do not have evidence that high-dose steroids have any role in patients with severe COVID. Okay. Same thing here that we've said. So here we have good evidence that low-dose steroids are associated with better outcomes in severely ill patients. No strong evidence or use of high-dose steroids for COVID-19. And remember, whenever you're using something for which you do not have evidence, it's important that PPB is informed, that there's proper documentation of patient outcomes as well. So going on to the issue of anticoagulation. So patients who are severely ill in hospital need to be on prophylactic anticoagulation. Many times people have either wondered whether they can give higher doses of anticoagulation to these patients. And this is a very recent study that looked at the effect of intermediate dose. So for example, instead of giving 40 milligrams of Clexane, they gave higher doses, 60 and above. So intermediate dose was a standard dose prophylactic anticoagulation. And the question was, is the higher dose better in terms of mortality and the need for more advanced respiratory care? So again, looking at this chart, they looked at patients for several days. These are patients who are severely ill and ended up staying in hospital for long. And they looked at the probability of the primary outcome, which was the need for more advanced thrombotic events, need for more advanced respiratory care. In this case, it was ECMO, or mortality. And the intermediate dose enoxaparin or higher doses of enoxaparin seem to be associated with a worse outcome or with a higher chance of attaining any of the primary outcomes as compared to standard dose enoxaparin. So basically what this tells us is that for your patients, give prophylactic dose Clexane. So the standard dose would be about 40 milligrams. If a patient has significant renal insufficiency, then you may need to adjust that dose downwards. So there are other repurposed drugs, which unfortunately people have been asking about as well. So one is Remdesivir. I'll mention Remdesivir just a little more after this and show some of the data from the Solidarity trial. The other one is hydroxychloroquine. One is lopinavir versus control, and previously interferon was also considered. So if we start with hydroxychloroquine, again, both in the recovery and Solidarity trial, they looked at hydroxychloroquine, and basically hydroxychloroquine had no impact on in-hospital mortality. If anything, probable tendency towards worse outcome, but not statistically significant. So hydroxychloroquine should not be used in patients with COVID-19. Looking at some of the antiretroviral regimens, again, there was no impact of lopinavir, ritonavir on mortality. So again, we should not use ARVs for COVID. Interferon, given IV, actually was associated with worse outcomes. So interferons were dropped from all the clinical trials and should not be used. There's been some recent suggestion about inhaled interferons, but you're waiting for better data on that. So looking at the issues of Remdesivir, and this is from the Solidarity trial, which so far probably has the highest number of patients who are enrolled onto the Remdesivir arm. And they looked at in-hospital mortality for patients on Remdesivir versus control, whatever standard of care was in those facilities. And basically there was no difference in outcomes for ventilated patients or for non-ventilated patients. Having said that, there are a few trials that have suggested that there may be some impact of Remdesivir. So for example, this NIH trial in the US that looked at Remdesivir and looked at mortality and time to recovery in terms of, do people recover faster by a day or two? And what they found is that in patients who were on no oxygen or only low flow oxygen, the recovery rate was better by maybe a day or two. In patients who are on high flow oxygen or ventilation, there was no difference in outcomes in these patients. So again, the issue of whether Remdesivir actually does make a difference or not is still not very clear. One of the things we know is that by the time someone is on high flow oxygen, they probably have fairly advanced disease. And if you remember the first figure I'd shown, by the time someone has more advanced disease, they really don't have virus. It's more of the inflammatory phase. So it may be that these patients got the drug fairly late when there was really no virus to control. And those who are not too ill may have gotten it early during the viral replication phase, but that is still not very clear. There's also been meta-analysis looking at various studies and comparing, Remdesivir versus no Remdesivir. And a few studies have shown that there may be some better outcomes with Remdesivir. If it is to be given, it needs to be given very early on in disease, not in your patient who now has, is in respiratory failure, for example. There's a recent study that has looked at Baricitinib. So, combined with Remdesivir in hospitalized patients. This study enrolled most of the participants at a time when corticosteroids were not yet standard of care. And there's a reason I'm mentioning that, and I'll just let you know about it in a short while. And they compared Baricitinib plus Remdesivir versus placebo and Remdesivir. And they looked at time to recovery amongst, especially amongst patients with high flow oxygen. And what they found is that the time to recovery was significantly lower in the patients who were on high flow oxygen or NIV as compared to patients who only got Remdesivir. Now, the question is that because this study enrolled patients at a time when steroids were not yet standard of care, it is not clear that this effect would still hold if a patient was on steroids, because the impact is less than what is seen with Dexamethasone. So many societies are now advising that if a patient can take Dexamethasone, then give Dexamethasone. If for whatever reason you're not able to use Dexamethasone, then you could consider the combination of Baricitinib plus Remdesivir. So it's not for all patients. And again, sorry, just to mention this, in Nairobi, we saw, usually when some of this data comes out, we have all these drugs flooding the market, especially from the Indian market. And a lot of people started using Baricitinib on top of steroids and the rest. We do not have evidence that there's any additional benefit of Baricitinib if a patient is already on Dexamethasone. Then there's the issue of interleukin-6 receptor inhibitors. Tocilizumab is fairly famous because every time there's a surge, everyone is running around looking for tocilizumab. So this, again, is anti-interleukin-6 receptor. So many patients, remember, in the inflammatory phase, you'll have high levels of interleukin-6, and that is responsible for a lot of the inflammatory damage that is seen in the lung. So that's the thinking behind use of anti-interleukin-6 inhibitors. So probably one of the most recent data on tocilizumab comes from the recovery trial. This was published fairly recently. And they've had a lot of patients now who have been on tocilizumab. It's probably the largest clinical trial, having the largest number of patients on tocilizumab so far. And they looked at mortality, and they also looked at discharge in patients who were severely ill. And what they showed is that the blue here is standard of care, and the red is the tocilizumab. And what they found is that there was a slightly lower risk of mortality in patients who received tocilizumab. And when looking at discharge alive, there was a higher chance of discharging someone alive if they were on tocilizumab. This effect was pronounced in patients who were rapidly deteriorating on oxygen and who had high inflammatory markers. So patients who had a CRP greater than 75. So whether tocilizumab would still be useful in patients who do not have high inflammatory markers is still not clear. So for those who are considering using it, it would be a patient who's rapidly deteriorating, given early after that deterioration, and who have high inflammatory markers, so a CRP of greater than 75. For that, we have clear evidence that it will work. Below that, then it is not clear whether there's any benefit. Remember, tocilizumab is really expensive. So if it is not clear that it will have any benefit, there's no point of using in a patient who may not benefit from the same. So a number of other studies have looked at tocilizumab. For many of them, there was really no impact of the tocilizumab. A few, which were fairly small, showed potentially worse outcomes. And now recovery, which is the largest, has had the largest number of patients on tocilizumab, shows some potential benefit in patients who have high inflammatory markers and rapid deterioration. There are a few other studies that were looked at before around convalescent plasma, for example, and they looked at outcomes such as discharge, and invasive ventilatory support. And if you look at the top one here, looking at 30 days or even fewer number of days, at 14 days or 30 days, there was no significant improvement with convalescent plasma. So we do not give convalescent plasma anymore. Sorry, that's the same one. We'd mentioned hydroxychloroquine before. Again, looking at multiple subgroups, usual care is better than hydroxychloroquine. So we should not give hydroxychloroquine. Ivermectin, again, we mentioned this briefly last week. Most of the studies that have looked at ivermectin have been fairly poor quality studies or low quality studies. There are a few randomized clinical trials that are currently going on. One of the clinical trials in patients with a mild to moderate disease did not show any positive outcomes. So far, we do not have any clear data that ivermectin works, and it should only be used in the context of clinical trials. So again, do not prescribe ivermectin. Do not encourage your patients to buy ivermectin as outpatients. We do not have any data that it works. So just to put all that together, what is it that we should avoid? So one, we should avoid azithromycin. We should avoid hydroxychloroquine. We should avoid ivermectin. Favipiravir, I didn't mention that, but there was a small study coming out of some of the Asian countries that suggested favipiravir may have some activity, but subsequently there has been no data to support that. We should avoid steroids in patients who are not severely ill, and we should not give anticoagulation to patients who are not severely ill. You have patients who request to take care of their patients at home. Maybe they have some setup for ICU or HDU, but our clinical experience is that these patients often come into the hospital when they're really ill and not very much can be done. Patients who have severe COVID often require a very intense amount of monitoring that may not be available at home. We must avoid unnecessary antibiotics. Remember that SARS-CoV-2 is a virus. Antibiotics have no role in treating this viral infection. So what to give? Again, just summarizing what we've said. If a patient is asymptomatic, then we do not give any treatment. If a patient is mildly symptomatic, then we can give symptomatic relief. So if they have a fever, they'll get some paracetamol. If they have a blocked nose, they could get, some antihistamine to decongest. In patients who are severely ill, low-dose steroids and prophylactic dose anticoagulation. If a patient is rapidly deteriorating on oxygen with a high CRP, then consider tocilizumab. If you're unable to use steroids for whatever reason, then you could try Remdesivir plus Baricitinib. So thank you very much. That is what I had today. Feel free to post your questions. We'll answer them at the end. And allow me now to invite Dr. Maritin, who will just give us some pointers on vaccines. Then we can have a discussion at the end. Thank you.
Good morning, everybody. Oh.
Morning.
Good morning. Good morning. I've just turned on my speaker volume. Allow me to share my screen. Oh, good morning. Allow me to share my screen. I hope you can see my slides. Dr. Tudorina, can you see my slides from your end?
Yes, I can see your slides. Continue. Thank you.
Okay, so I'll just give us a quick overview of COVID-19 vaccines. Just talking about even the newer antigens. And then some of your questions, you can bring them in the Q&A session. And one of the disclaimers I have is I don't have a very clear update from the deployment task force or the committee. So I'll not be talking about when are the vaccines coming. But we know that J&J will be coming in the coming months, and Pfizer, from what we've heard in the press. So my talk will not be really talking about the availability of the second doses and the other logistical challenges that are all over being experienced everywhere. So mine is just a technical presentation. So this is the outline of my presentation, looking at the vaccine platforms and mechanism of action. And I know previously when we've spoken, we focused more on the AstraZeneca. So for this talk, I've included the other antigens because they will be with us in the coming months. We look at the vaccine's characteristics, the safety concerns, efficacy, and then I've added a slide or two on vaccine mix and match. So basically, I put this slide here to just remind us the structure of the virus, and just to emphasize that most of our vaccine antigen have targeted the spike protein. So when we talk about the mRNAs, they are still targeting the immune responses that are generated by the spike protein. When we talk about the viral vectored vaccines, again, they're targeting the spike protein. And we know that the spike protein is very important for binding to host cells and for facilitating entry of the SARS-CoV-2 virus. And therefore, it's been a major target of vaccines as well as even other therapeutics. So these are the available platforms that have been deployed in COVID-19 vaccines. But also more importantly, is that newer platforms have been have reached successes that had not been seen before. But just to remind us that we still have traditional platforms, which are including the killed and attenuated. So the viral vectored vaccines, the two ones to remember is the AstraZeneca vaccine, which is using the chimp adenovirus. And then we have J&J vaccine, which is using the adenovirus 26, AD26 viral vector. And it's carrying the non-replicative genetic material that will encode the spike protein. So those are the two examples. And then for DNA vaccines and mRNA vaccines, we actually have mRNA vaccines. We have the Pfizer vaccine and the Moderna vaccines, and the genetic vaccines deliver the pathogens genes using an mRNA technology, sorry. And then there are other protein vaccines. We don't have any yet in advanced phases. Okay, we have the Novavax, but it's not in our part of the world, but it's part of whole protein or fragments of made from the SARS-CoV-2 spike protein that's inducing an immune response. And then we also have killed or attenuated virus. We don't have any within our part of the world, but there's one that it's called Covaxin, made by Bharat Biotech in India. And then we also had of the vaccine from China. I think it's called Sinovac. Again, it uses killed virus. So we don't have yet deployed, but we know that Sinovac received WHO emergency use listing. The only challenge is that it's very costly to produce the vaccine, and therefore even cost may be a limiting thing in terms of availability within the COVAX facility. So looking at the different vaccine antigens and the platforms, basically this chart summarizes the differences. So we have the mRNA vaccines, of which we have the Pfizer vaccine and the Moderna vaccine. And you can see in terms of storage, that's why we haven't had these vaccines in our part of the world, because you require very cold storage. Are given intramuscularly, and the dose schedule is for Pfizer is 3 weeks apart, so 21 days between first and second dose, while Moderna is given 4 weeks apart. But they have both high efficacies, 95% and 94%. And we'll talk about later what are their efficacy against the different variants that are currently circulating and are of concern that we talked about in our last webinar last week. For the non-replicating viral vector vaccines, we have the AstraZeneca, we have the J&J, and then we also have Sputnik, which was available in the country. I think some people received it earlier on, but it's not widely being used in our part of the world. But I'll not talk about the others, only maybe if they come up in the Q&A. So I just did this table to summarize because we'll have the J&J vaccine, I understand, from August, and it's really important for us to know. So comparing the two characteristics, both of them are viral vectored. They require, for AstraZeneca, we require 2 doses of 0.5 mil injected on the deltoid left arm. And the dosing interval, which the country has selected, is 12 weeks. And the recommendation from the manufacturer is to use the same vaccine for first and second dose. And if you have to give other vaccines, you should space them within an interval of 14 days after receiving the AstraZeneca vaccine. For J&J, which we'll be deploying, and maybe these are some of the things that have made it to be selected, is you need a 1 dose. It's always easier when you have a vaccine which requires a single dose, because logistically, it's much easier to deploy. And you don't have to worry about people who do not complete their schedule because of a time interval. It's again given IM on the left arm as a single dose and 14 days interval if you have to give other vaccines. For the mRNA vaccines, I put them here because we understand we might get the Pfizer vaccine, I think 1 million doses in the coming months. And basically, as we get more and more data about safety of vaccines, and we've had this from other parts of the world, younger people may have to receive the mRNA vaccines because of the risk that has been associated, the vaccine-induced thrombocytopenia with thrombosis. So in other countries, you find that people who are 30 years and younger are actually getting the mRNA vaccines, because when you weigh the risk and the benefits, and the fact that we have several cases of the syndrome, then people who are younger may benefit from mRNA vaccines. But just to summarize it, they are both given as 2 doses by IM injection. Pfizer is 21 days apart, but the Moderna vaccine is 28 days apart. And then for Pfizer, it was initially recommended for 16 years and older, but in the recent past, they've actually reviewed that so that people who are 12 years to 15 from clinical trial data, they can actually receive the vaccine. So it's recommended for persons 12 years and above. In terms of side effects, common side effects include pain, swelling, redness at site of injection, chills, tiredness throughout the body. And this start 1 to 2 days after receiving the vaccine. But a newer side effect that I haven't really captured in my future slides, but I'll talk about it here, is that the mRNA vaccines have been associated with myocarditis that occurs several weeks after vaccination. So that would be of concern. And this is data that is being monitored globally to try and document that. For the Moderna vaccine, dosing interval is 28 days, recommended for 18 years and older, but a lot of work again ongoing in the younger population to see its safety in children. And then side effects are more or less similar: pain, swelling, redness at site of injection, chills, tiredness, headache throughout the body. And then this start again 1 to 2 days. And then the myocarditis again has been described because it's an mRNA vaccine. This has been a frequently asked question, and I put this slide here because I know someone might want to ask it in the Q&A. Who are these vaccines recommended for? So initially, because of the age risk and the categorization of people who are likely to have adverse outcome following infection with SARS-CoV-2, we can clearly see that people who are 65 years and older are recommended to receive the vaccine. Again, people with comorbidities, because we know comorbidities contribute to adverse outcomes and mortality, then it's recommended for people who have comorbidities, and this list is not exhaustive. So obesity, cardiovascular disease, respiratory disease, diabetes, hypertension, all these comorbidities, people with these comorbidities are recommended to receive their vaccination. And then for persons who are aged 18 years and above, Again, these are now the manufacturer's recommendation in terms of an age categorization, because these were the people who are included in the clinical trials. And as the data keeps on coming, this age may be revised downwards. But again, when you're looking at the pediatric dosing, you might need to, the manufacturer may need to repackage and reduce the active ingredients within the vaccine, depending on the age group of the individual. So it may not be that an umbrella statement where you're using adult vaccines for children, but there may be specific vaccines modified from the adult vaccines to be used in children. So currently, 18 years and above, particularly for the viral vectored vaccines and Moderna. But for the Pfizer vaccine, the age group now is 12 to 15 years plus 16 years and above, so above 12 years. For these other vaccines, it's really because there was no clinical trial data, but this is a changing goalpost, and this may be revised once clinical trial data is available. Contraindication, again, history of anaphylaxis to any component of the vaccine is a contraindication. And what has been thought to drive the anaphylaxis is the excipient. So polysorbate 80 in the viral vectored vaccines, and then polyethylene glycol in the mRNA vaccines. But the anaphylaxis reaction have been fairly rare, particularly for the viral vectored vaccines. A few cases have been described for the mRNA vaccines. And people who develop an anaphylactic reaction to a first dose should not receive the second dose of the vaccine. These are precautions that have been recommended for the vaccine. So the vaccine is administered under healthcare supervision. Appropriate medical treatment should be available in case of allergic reactions, and a 15-minute observation period is ensured. And we've seen this in our facilities where you have to stay after receiving the vaccine. Acute febrile illness, such as a temperature above 38.5, should not postpone vaccination. If somebody has an ongoing fever, they should postpone that vaccination until the fever settles. And this is because it may confuse the picture, and someone might think that they have actually adverse event following immunization, but it may be that the fever may explain that. And we know that in our setting, we have so many causes of fever, of which even COVID-19 illness may explain the fever. So again, trying to encourage people to have the fever settle before they go for vaccination. Presence of any minor infection, such as a cold or a low-grade fever, is not really a concern and should not delay vaccination. In patients who are on anticoagulant therapy or have a coagulation disorder like hemophilia, then you are concerned about giving intramuscular injections because you can precipitate hematomas. So that's you need to work with the hematologist to advise on the timing of vaccination. For this group of people, I put this again here because it's a frequently asked question among healthcare workers or among people who are in the priority group. And they really want to know whether they can come for vaccine if they are pregnant or if they are breastfeeding. And these groups of people were underrepresented in the clinical trials, and currently work is ongoing, and different vaccine manufacturers are doing trials in populations with high numbers of people with these conditions or these physiological situations like pregnancy and breastfeeding to try and generate more data on the safety. So therefore, when you have a person who's pregnant or breastfeeding, or a person living with HIV, immunocompromised persons, or people with autoimmune conditions, you have to look at the risk and benefit analysis and look at it. For example, if it's a healthcare worker who's breastfeeding and they're frontline, for a person, the logical conclusion would be to recommend the vaccination. These other groups of people living with HIV, immunocompromised persons, persons with autoimmune diseases, the rationale for, again, maybe perhaps individualizing the risk and benefits is because these people, they do not really have, understanding the vaccine platforms, there's nothing to put them at increased risk of having adverse outcomes. But the challenge is that the immune response or the antibody or cell-mediated immunity that's accrued following vaccination may not really be predictable because these people were underrepresented in the clinical trials. And perhaps maybe people with HIV may require even an additional booster dose. So we don't have enough data, but looking at the vaccine design, the vaccine is unlikely to harm them. We know that different candidates may come with additional requirements. For example, life-attenuated vaccines are contraindicated in these 3 groups of people because we know that they can be a risk of reversion to virulent forms and causing disease in the people. But for the mRNA vaccine and the viral vectored vaccines, the risk of reverting to virulence is not really there, and therefore is a frequently asked question, and I put it here. And this is people want to know, if I've suffered SARS-CoV-2 infection, can I get vaccinated? So people who have previously had SARS-CoV-2 infection may receive the vaccine regardless of whether they have symptoms or whether the initial infection, the natural infection, was symptomatic or asymptomatic. And the rationale for this is that we are not currently testing people to exclude a prior infection before offering vaccines, because it would increase the cost significantly of deploying the vaccines. So the most important thing is, if you've already suffered a natural infection, you can still get vaccinated. Then the next question is, if I'm currently suffering COVID-19 illness, can I go for the vaccination? And I remember I was asked last week, and I provided an answer to this. So what is recommended is that persons with acute COVID-19 should not be vaccinated until they've recovered from the acute illness. The national deployment guidelines recommend an interval of about 10 days. Other guidelines like WHO interim guidelines on AstraZeneca vaccine specifically recommend even a period of 6 months. So when you're looking at this diverse, it clearly shows us that we do not have maybe clinical trial evidence. When you read the manufacturer's insert, they actually recommend a period of up to 4 weeks between the acute illness. So what I normally tell people when they ask me this question is really to wait the 4 weeks period, so that in case there's adverse event following immunization, especially when you recover from natural infection, the amount of antigens still circulating in the body is high, and that can trigger sort of an immune response, an immediate immune response, because when you're giving the vaccines, you're adding more antigens and the body is responding to those antigens. So a period of 4 weeks makes a lot of sense in terms of that interval. Persons who previously received passive antibody therapy, and Dr. Lois just mentioned about the monoclonal antibodies that are used. And for these people, it's recommended to wait at least 90 days so that you don't have the antibody therapy binding the antigens that are like being introduced through the vaccine. So a period of 90 days is what is recommended. These are some of the safety issues, and I don't want to spend too much time with this, but you can see the ones that are very common are the expected ones, because when you give the antigens, you want an immune response. And then we have uncommon ones, including decreased appetite, lymphadenopathy, dizziness, abdominal pain, rash, pruritus, and then very rare, occurring in less than 1 in 10,000, which is thrombosis in combination with thrombocytopenia. And globally, it's thought the occurrence now is estimated to be around 18 cases for about 1 million people vaccinated, particularly in the European setting. In the UK, this is data from the UK, where they've reported a number for people who received the AstraZeneca vaccine. And we'll talk about that in a short while. For J&J, because we'll be deploying this in the coming months, these are some of the side effects so that we can just be aware of this. And we can see the very common are similar to the ones for AstraZeneca. So headache, nausea, fatigue, myalgia, injection site pain. For the common cough, arthralgia, fever, injection site redness and swelling and chills. And then uncommon tremor, sneezing, oropharyngeal pain, rash, hyperhidrosis, muscular weakness, pain in extremity, back pain. And then rare, hypersensitivity and urticaria. And then very rare is thrombosis with thrombocytopenia. So you can see the common thing with the viral vector vaccine, they share this thrombosis and thrombocytopenia, but the mechanism hasn't been fully elucidated, and we are waiting for that data. So a little bit about this. This is was observed in the European, in Europe when the AstraZeneca vaccine was deployed, and it's a combination of thrombosis and thrombocytopenia that has been reported following AstraZeneca and J&J vaccine. Severe cases present as thrombosis with thrombocytopenia, and this is including arterial and venous thrombosis in unusual places. So cerebrovenous sinus thrombosis, as well as mesenteric vein thrombosis. And majority of cases occurred within the first 7 to 14 days following vaccination. It was more common in women under 55 years of age, and some had a fatal outcome. So, so for us as healthcare workers, we just need to be aware and to be alert to the signs and symptoms of thromboembolism and thrombocytopenia. And this is part of the education of the people who come for vaccination. And we tell them that if they develop shortness of breath, chest pain, leg swelling, and persistent abdominal pain following vaccination, they should present back to the facility. Another thing is that vaccine recipients may develop neurological symptoms such as persistent headache, blurred vision after vaccination, or even bruising. For example, if you have petechiae and other bruising on the skin outside of the site of the vaccination, again, you should seek prompt medical attention, because this can be a sign of thrombocytopenia. So when we are evaluating these individuals, we have to start off with a platelet count and then now confirm whether they have the rest of the things that characterize the symptoms. So I'm approaching towards the end of this presentation, and just to cover a little bit about vaccine efficacy and effectiveness, because again, this has been a frequently asked question about how effective is a vaccine against the different variants. So when you talk about efficacy, this is what is found in the clinical trials when everything is controlled. And effectiveness means how the vaccine performs in the real world. So for example, Moderna vaccine in the clinical trials had an efficacy of 94.5%, and Pfizer had an efficacy of about 90%. When you go to the real world, because you're not controlling for so many things, you might find a reduction in the efficacy. And we have data from Israel where they used the Pfizer vaccine, and they clearly demonstrated there was no difference between the clinical trial efficacy and the effectiveness of the vaccine when it has been deployed in the real world setting, which is very encouraging, because it just shows that the vaccine is effective. However, when you're looking at effectiveness, different things now come into play. Circulating variants is one thing that is difficult to control in a clinical trial. But now in the real world, we have different variants and mutations that have occurred to the virus, and that has actually reduced the effectiveness of the vaccine. So this is data that was published in the New England Journal of Medicine, showing the efficacy and neutralization of the different variants. So the B117 variant has recently been renamed. It's now called the Alpha variant, and it's the UK. For those of you who remember things by countries, this is the UK variant. P1 variant is a Brazilian variant. It's now been renamed Gamma. And F01Y2 variant is previously the B1315 variant, which is the South African variant, which is now, I believe it's the Beta variant. The Indian variant, I think, is not included in this analysis, but it's been renamed the Delta variant. So you just have to remember, Alpha is the UK, which was the first. Beta is the South African, which has been the second. Brazilian is the third, it's called the Gamma, and the fourth one now is the Delta, but there are other variants that are circulating. So looking at this, what I just wanted to highlight in this, you can see the 66% efficacy in the clinical trial, and then in preventing severe COVID, 95%. However, there's no known much data in terms of the UK variant. This is from analysis of published literature, but I'll show you what the modeling data seems to suggest. For the Pfizer, the reduction is minimal. So for the UK variant, it's decreased by 2 times. And for the Brazilian variant, it's decreased by 6.7 times. So a reduction by 6.7. So we can see really the implication of having circulating variants and the immunity that's sort of induced, that you, even though you're vaccinated and a new variant, you get exposed to a new variant, you might still get infection, maybe not get severe effects, but you can still get infected. So you can see the table has a lot of incomplete parts of it, just focusing on what was available in the clinical data. And this is data from University of, I think it's Washington, University of Washington, modeling the different efficacies from the published data. So what is estimated for the Pfizer vaccine, a reduction for the various circulating variants. So for the Indian variant, it's estimated to reduce to 86% efficacy. And then for the South African variant, the Brazilian variant, as well as the Indian variant, reduction to 76%. And then again, for the Indian variant, so 76 to 72% estimated reduction. And we can see again, the mRNA vaccines, they have a modest reduction to around 70-something percent. When you look at the J&J vaccine, sorry, let's start with the AstraZeneca vaccine. We can see for the South African variant, the efficacy is just 10%. And that's why South Africa stopped using the AstraZeneca vaccine, because they had the South African variant. It's actually what's driving the epidemic now. But the protection that would have been offered by AstraZeneca vaccine would just have been about 10%. And when you look at the J&J, the estimated efficacy for the South African variant is around 64%, which is not too bad. And then for the Indian variant, around 56%. So even as we think of introducing the J&J vaccine, we can see that we'll derive significant benefit from that protection. But I know, having said that, I know a lot of questions now may come up in the chat box because I'm not able to access that. For those of us who've received 2 doses of AstraZeneca, I know somebody will want to ask, should we then get a J&J booster? But we don't have, I don't have that answer. So I won't talk about this slide. And basically, just to bring us to this mix and match, and we have data from 2 trials. We have the COMCOV trial, which was an Oxford, led by Oxford Vaccine. And they're looking at vaccinating people with 2 different vaccines at different intervals. So there's the COMCOV-1 and COMCOV-2 trial, but I'll just talk about them in general. So in the design of the study, you prime the vaccinee with AstraZeneca vaccine, and then you give the second dose with a Pfizer vaccine. At the time of interim analysis, they had recruited 830 participants, 50 years and older. So this may limit our extrapolation of this data to a younger population. The preliminary safety results indicate that mixing vaccines leads to a higher reactogenicity and more frequent side effects. And this may be related to, this may lead to a stronger vaccine efficacy and broader protection, but the sample size is thought to be too small, and there was no placebo control group. And therefore, even with a high reactogenicity, it's a bit difficult to predict whether this would be the strategy going forward. And particularly, this study contradicts what has been found from a similar study with a similar design done in Spain. It's called the COMBIVAC study, which enrolled 670 participants aged 18 to 59 years who had received 1 dose of AstraZeneca vaccine. And then the second dose was the Pfizer vaccine. So at the interim analysis, they analyzed data for 450 participants. And what they found from this study, it was safe and effective. The side effects, which were reported in both studies, the side effects were self-reported. They had headaches and muscle pain, which were reported in 1.7% of the individual. But in the COMCOV study, the headache and muscle pain was higher at 34%. So again, those are some of the contradictory findings, that one group considered it a bit like the side effect profile may seem higher or overestimated, while the Spanish study. So I think what this basically says, we need more data from larger clinical trials. And we know that the European region, Germany and other countries, are already mixing and matching, because some people receive a first dose of AstraZeneca and they were younger than 30 years. And that group of people have been said they'll receive a second dose of an mRNA vaccine. So we'll await real life data to really answer these specific questions. And this brings me to the conclusion. And these are really the concluding things. We've seen the platforms, we've seen the vaccine safety monitoring, we've seen the effectiveness. And for the mix and match, we need more data. So let me stop there and we'll embark on the Q&A.
So thank you very much, Dr. Maritim, for an excellent presentation. Thank you very much, Dr. Maritim, for an excellent presentation. We have just come to the end of our time, so we'll take very few questions and we'll try and keep some of the questions for the next session that we have. So there are a few clinical questions and also some vaccine related questions that I think were answered as the session went on. There are 3 sticky questions that I'll ask you to answer. So one is issue of pregnancy and vaccination. One is efficacy with delay beyond 3 months. So most people are saying people got vaccinated in March and they haven't had their second dose. What impact does that have on efficacy? And I think the third one, maybe just those three is what we'll be able to take, is the impact, whether we have any data on side effects from the Kenyan context. So to the clinical questions first. So I think some are asked because the people missed the first part of the presentation, because there are a lot of questions around zinc, when should we give zinc and vitamin C? And just to summarize, what has impact and what has no impact. Zinc, vitamin C, vitamin D have no impact on COVID, do not prescribe them. Ivermectin, we do not have data, do not prescribe. Azithromycin, no impact, do not prescribe. A few people are concerned about, oh, but really want to use antibiotics. Again, remember, unless you're treating a bacterial infection, antibiotics have no role in COVID. And that is important. We're seeing a lot of abuse of antibiotics, and that will get us in trouble because we'll have a lot of selection for antibiotic resistant organisms. There's been a question around, one was on around post-discharge anticoagulation, which we didn't mention. So I think the thing is, there's no clear data on post-discharge anticoagulation. You should not routinely discharge patients on anticoagulation. The decision for anticoagulation has to be individualized. So which patients will end up with anticoagulation post-discharge? One is patients who are being treated for a PE. So if your patient is doing really badly in hospital and are not clear what's happening, you could consider doing a CTPA to look for PE, in which case you give therapeutic dose anticoagulation. Two, you could then think at who are your highest risk patients. So for example, in our practice, if you have a patient who is has another risk factor for clotting, so they have another coagulopathy and they're not going to be up and about. Remember, as you're discharging your patients, you want to ask them to remain active. Sometimes patients leave and because they're still not feeling so strong, they just lie in bed throughout. So you want to encourage your patients to be active once they are discharged. And if a patient, for whatever reason, is unable to move and has other reason for you to think that the risk of coagulation is high, those are the only patients you may have a discussion with the physician around the role of post-discharge anticoagulation. It needs to be a discussion with your physician. So please involve a larger team in those discussions. But routine post-discharge anticoagulation, we do not have any data to support that. Someone asked about pirfenidone. So pirfenidone is an antifibrotic agent that works in multiple ways, but some of the ways is that it may inhibit TNF-alpha, transforming growth factor beta, and other cytokines that may be responsible for fibrosis. So it is thought that by giving pirfenidone, you may have some alveolar protection against fibrosis. We do not have any data to support this. Pirfenidone has previously been used for other causes of lung fibrosis, given at fairly high doses over a long period of time. Chest physicians, some have prescribed pirfenidone, but the truth is we do not have any data to support this. Experience with managing patients and seeing them in the post-COVID clinics is that many of those who had significant lung involvement tend to do well with time. So they may have issues early, but with time they do well, but we do not know about the long term because we've only had patients for just over a year. So at this point, we do not have evidence. There are a few questions on oxygen therapy, and what we'll try and do is maybe in one of the next sessions, we'll organize for a speaker just to talk about oxygen therapy. Thank you very much. I'll give it to Dr. Maritim to answer the 3 questions so we can close in a few minutes.
So I'll start with the third question, and this is on the side effects. Am I having an echo?
Sorry, is it me?
Okay, yeah. So the side effects from a Kenyan context.
Yes, ADRs from Kenya. Oh, sorry, you're in trouble. Okay.
I can hear myself.
You can hear yourself.
Can you hear me?
Yes, loud and clear, no echo.
Can you hear Dr. Maritim?
Can you hear me?
Maybe you mute one device, then you continue, but you're hearing you loud and clear.
Okay. So I was having an echo, but I hope you can still hear me. So I'll start with the third question about the side effects from the Kenyan context. So when we give the vaccine, the healthcare workers who are administering the vaccine educate the recipients on what to report and how to report. And we have a portal through the Pharmacy and Poisons Board, which can be uploaded from a mobile device or through a computer or physically. If someone goes, they can actually report the side effects which they've gotten after the vaccination. So all this data goes to the PPB, and then the PPB liaises with the National Vaccine Immunization Program, where this data is collated. And for example, if someone has a serious adverse event, then they can be guided in terms of what to do. So serious ones are the ones that require hospitalization, and they can they needed to be acted on immediately to prevent ongoing harm or even to avert a life lost. So from the Kenyan context, most of the side effects that have been reported are actually what were found in the clinical trials. I don't have that data here, but when we have the next presentation, I'll borrow a slide from PPB, but we can see a lot of the common, very common side effects. Last week when Kericho presented, they had a case of a patient who has been managed for COVID, and we've asked them to report this case through the national system so that we can have it within our database. Because when all the cases are compiled, then the National Vaccine Safety and Advisory Committee sits and adjudicates on causality and are able to look at the events and other extenuating factors to be able to say this was actually vaccine related. So I don't have that data, but what I can tell you for now, most of the side effects were what were expected from the clinical trials, and we'll have an updated slide when we have the next presentation. The second question was about the efficacy, and I know some people have been waiting for the second dose. They've been moving from facility to facility, and because of the shortage, they've not been able to get. So the question is, if you receive the second dose beyond 3 months, will the efficacy still be there? So what we have data from clinical trials and even real life situation is up to a 12-week interval. And initially, remember the manufacturer had recommended a dosing interval of initially even 6 weeks, then it went up to 8 weeks and then 12 weeks. And these are new vaccines. When you design the vaccine, part of phase 2 clinical trials is to find out the dosing, the amount of dose, as well as the dosing schedule and the dosing interval. And initially, it was thought that having a shorter dosing interval would be adequate. So the first dose acts as a prime, the second dose acts as a boost. And therefore, from data from the UK, where they actually use the prolonged dosing interval as a vaccine sparing modality, where there was a shortage of vaccine and they wanted to prioritize vaccinating people with a first dose, the 12-week interval was actually found to be more beneficial to compare to, for example, an 8-week interval. However, beyond 12 weeks, we don't have that data from clinical trials, but we don't clearly know, but it may still be useful that the boost may, when they compare the 12-week versus the 8 weeks, the efficacy or the immune responses from the 12-week interval was beneficial. And therefore, inferring the same thing, maybe the 14-week would still be the immune response may be much more robust. Having said that, really, I think once there have been vaccines that were received this week. So for those of you who are looking for your second dose, please try to go to the facilities and get the vaccine at the earliest time possible so that you don't lose much more time. Having said that, in a real life situation, the UK has just opened up vaccination for a younger age group. So my daughter was invited for a vaccination. She got her first dose. So I was worried that the interval may be too short if she's getting a Pfizer vaccine. So in that setting, and I was able to find data for that, they're actually giving Pfizer vaccine at a 12-week interval. So although the vaccine manufacturer recommends a 3-week interval, they have preliminary data from that setting in the real world deployment data to even suggest that you can stretch that to a 12-week interval. And I hope that from the data that I was able to review, that it's very promising that even these intervals, because these are new vaccines that are being deployed, we are collecting data and gaining insights even as we deploy the vaccine. Coming to the first question, which I hope I captured it clearly, it was, I think, a question related to, can the vaccines be given in pregnancy? Yeah, and the answer to that is yes, if we are using the AstraZeneca vaccine, but more so, particularly for people who are frontline, whose risk for getting COVID in their line of duty or care is puts them at increased risk of getting COVID, because we know that, again, the impact of COVID-19 in pregnancy, in terms of the outcomes and severity of illness, particularly in late pregnancy. We've had cases of patients progressing on to severe COVID and critical COVID because of advanced pregnancy. So for healthcare workers, the recommendation is still yes. For the general public, I think my advice would be, if you're, for example, someone who maybe is working from home, is not mingling with a lot of people, maybe the public health interventions would suffice until we have more data to be able to balance risk and safety. And the reason I'm saying that, these vaccines have just been deployed for not even a year yet, and we are collecting data. And some of the data that we have is more of short-term safety. We don't have too much data on long-term safety. And I think as we continue to get more of this long-term safety data, we need to see how to balance where you're weighing risk and benefit. And therefore, I will not make an umbrella statement to say we will vaccinate all the pregnant women, because even our national deployment guidelines still recommend an individualization where you're weighing the risk and benefits on a case-by-case basis. So I think I'll stop there and hand back to Lois. Thank you.
Thank you very much, everybody. I think we've tried to answer most of the questions. There are a few that we have not answered. Some, the answers came out during the presentations. So if there are any questions that we haven't handled, pardon us, we can handle them next week. I think we've come to the end of our session today. Thank you all for joining. Wish you a good weekend, and I hand it back to Dr. Thuranira.
Well, thank you very much, Dr. Lois and Dr. Maritin, for the wonderful presentation. See why I insisted we do a session today. So next week we'll have another presentation from next week. Probably we'll get a guest.
Okay, goodbye, everybody. Have a good weekend.
Bye.